Good evening. I'm here to take class on prosthesis. Actually, I'm from the Orthopedics department. And my name is Dr.B.Marbaniang. Many of you have gone through the classes regarding amputation. And I guess Dr. Ashish, I think he took the class on amputation. And as well as many of you are aware by now, what is an amputation, what are the causes of amputation. So by definition, I think you can see the slide projected there. A prosthesis is a device that is designed to replace as much as possible the function or appearance of a missing limb or body part. Out here when we talk about prosthesis, in my subject, I'm talking about extremity prosthesis. Not the heart prosthesis or not the hip prosthesis, the internal one, but we're talking about the external prosthesis, okay? Or we call the artificial limbs, in other words, okay? So what it does is that it's a device which is designed to support, supplement or augment the function of an existing limb or body part. Okay, existing limb means sometimes patient after being amputated, they have an existing limb or residual limb we call it. So that device, this processes, it supports or supplements, okay, the function of the existing body part. So the most common causes as you've seen and as you've known, the causes of amputation, as you see there in the slide, there's a correction of congenital deformity. Sometimes some patients are born with congenital deformity wherein the extremity or the limb, so as to say, cannot be of any use. Okay, the patient cannot walk properly or he cannot eat properly, he can either use his hand or his feet properly. So in that case, what we do is that they have to amputate the hand or the leg for getting a correction of the congenital deformity. And diseases such as blood vessel disease called peripheral vascular disease or PVD, then diabetes, many patients are having diabetes these days. Some patients have got these diabetes that infects the entire limb. So in order to save the patient or salvage the limb, what they do is that they have to amputate the residual limb, okay? Or some osteomyelitis, which is the infection of the bones, okay? And then the other one is the trauma. 75% or 80% of the amputations are mostly related to trauma, okay? Then there are also some tumors like osteosarcoma, which is the tumors, which is the carcinoma of the bones, okay? Wherein the bones and the muscles have to be removed, okay, in order to save the patient. Okay, these are some of the most common reasons for an amputation. Okay, so in the amputation rehabilitation program, this is very important. Kindly remember and record this. The amputation rehabilitation program, what do we do? First of all, the treatment, we help to improve the wound healing and stump care. Okay, wound healing and stump care, as you've seen, after the amputation, dressing has to be done. Intermittently, after 2 days, dressing has to be done so that there's no recurrence of the infection. Okay, no recurrence of the infection. We have some cases out here in our hospital here where there's a recurrence of the infection because of improper wound healing. Okay, so what they do is that they go for antibiotics, high doses of antibiotics, as well as proper dressing. Okay, very sterile dressing is required to help in improve the wound healing. Okay, then when you talk about stump care, what is stump care? Stump care means like after the patient is amputated, what happens is that there's a swelling of the limb. Okay, there's a swelling of the limb or sometimes there's contracture of the proximal joint. So in these cases, what happens is that a proper stump care management has to be done. A proper stump care management has to be done. In this case, when we call about stump care, we talk about stump bandaging. I think many of you have seen crab bandage application in cases of sprain or mild ligament torn. Okay, those are crab bandaging application in different cases of trauma. But when we talk about stump care, I think you've heard about figure of 8 bandaging. So in this case, what we do is that when we try to get the shape, okay, because the normal anatomical shape of the limb is always a cylindrical, okay, is always a cylindrical shape, okay. So what we do is that we try to then and bring the stump into a cylindrical or conical shape. Okay, when we see our limbs, our thighs, or legs, or our hands, we see it's almost in a conical shape or a cylindrical shape. So in order to avoid any bulbous shape, okay, or any flabby stump, we take a proper stump care, which means by crab bandaging in a figure of 8 fashion. Then there are activities to improve the motor skills, okay. Activities to improve the motor skills, which restores the daily activities of living. Because see, our patient after being amputated, suppose we're talking about the upper extremity. Now our patient, we having a normal hand, okay, the normal anatomical hand, we easily use our hand. Okay, for some of you who just joined, we're taking a class on prosthesis. Okay, so we have already talked about what is a prosthesis. Just to revise again, it's a kind of it's a device, external device, which is fitted to a limb in order to replace the missing part of the limb or the body. Okay, now we're reaching on the topic called the amputation rehabilitation programs, because prosthesis always deals with amputation. When there's an amputation, it directly relates to a prosthesis. Okay, but depending upon the severity of the amputation. Okay, now we're talking about the rehabilitation programs, because without this rehabilitation programs, there's no point of having a prosthesis. This is one of the management of an amputee. Okay, a person whose limbs are amputated is known as an amputee for us. Okay, so what we do is that as I was talking about the activities to help improve motor skills, because these are finer motor functions. Okay, these are finer motor functions which requires a very important training for them not able to use, that is the processes. Okay, now like how to correlate the brain and hand function, how to correlate hand and brain function, or how to walk, even the gait. We have used to give gait training. Okay, because the patient after fitment of a limb has to have a correlation of the entire body in order to perform his activities of daily living. When we talk about activities of daily living, means standing up, brushing, combing his hair, walking around, doing his daily activities. These are all the activities we do in our day-to-day basis are known as activities of daily living. Okay, so that the patient can attain a maximum independence. Okay, now I think many of you have seen on the roadside a beggar sitting, begging. That's not independence, that's a dependence. Okay, they have to depend on people giving them alms or giving them some donations. Okay, but what we're trying to do here is that a patient have to reach a maximum independence. Even after the rehabilitation, the patient can come back to almost normal activities as he was doing pre-amputation period. Okay, the another point is that exercises. See, what happens after the amputation is done on a patient, many of the patient doesn't use the residual limb. They don't use. Okay, so there's a muscle wasting, or we call muscle dystrophy. Okay, muscle dystrophy is there. There's a wasting of the muscles. But in order to have a very strong residual limb, exercise is a very important part. Okay, so the physio people, what they do is that they teach this patient the exercises, the various exercises in order to strengthen the muscles as well as to avoid the contractures of the joints. Okay, this is where the exercise comes as a very important role of function. So after all these things are being done, then comes the fitting and the use of artificial limbs or the prosthesis. Okay, then comes our part where we take the casting, the measurement, all these parts are taken, and then we do the fitment of the prosthesis. But during the duration of using a prosthesis in a patient, what happens is that there's a pain. Okay, there's always a pain post-operatively, which is a post-operative pain, and there's another pain which is a phantom pain. A phantom pain, so as to say, I think most of you have known about this, but just to remind you, phantom pain is a pain that a patient feels that his normal limb is still intact. Okay, like suppose we hit some object, we have a pain of our fingers. So even these amputees, they've got the same feeling of these fingers are still there, there's a pain in the finger, or there's a pain in the leg, in the feet. Okay, they have the same feeling. So this feeling is known as a phantom pain. Phantom means when the limb is not there and still the pain is there, that's known as a phantom pain, which is a sensation of pain that occurs below the level of amputation, which means the normal limb is not there anymore, but the patient still feels the pain. So this is a very important part, because if there is not a management of this phantom pain and the post-operative pain, the patient won't be able to use the prosthesis. Okay, so it's very important. Counseling needs to be given to the patient for management of the pain. So in the next slide, again continuation of this amputation rehabilitation programs, we also need the emotional support. Okay, because see, I've seen many of the patients pre-amputation period, they go through a lot of grieving. Okay, they go through a lot of grieving. So many of them don't want to get amputated, but it's in a life-saving matter, they have to undergo amputation. Okay, then what happens is that a patient feels very abnormal in society. You know, when he walks, I think when patient walks without a hand, he tries to hide inside a jacket. Many of my amputees who comes, what happens they do, with the thumb, they put their hands inside the jacket. They don't want to show that their hands are not there anymore. And even after the fitment of the prosthesis, which looks cosmetically almost the same, they still have this feeling of grief. Okay, that my limb is not there anymore. I don't look normal anymore to society. So emotional support is also very important. Okay, then we have the use of assistive devices. This assistive devices, in case of patients like, suppose now a patient's got his hand amputated, what happened is that he needs a kind of a gripping material or gripping tool for picking up things, okay, or for buttoning his shirt. These are all assistive devices, or even for walking, you know, crutches or walkers. Those are also assistive devices which assist the patient to walk using a prosthesis. Because sometimes a patient feels very uncomfortable, or he feels very scared to walk. He might fall off or might fall down. So what he did, he used these walkers and crutches as an assistive device to help him mobilize, okay, get immobilized, okay. Then comes the nutritional counseling. Nutritional counseling is also very important to promote the healing and health. This is a very important aspect of nursing, I think. And vocational counseling. Vocational counseling comes in a part where, see, patients, before they do their normal work, they can do their work as they can do before. But when they lose a limb, especially the upper extremity, they cannot do the normal work that they used to do before. So vocational counseling also is very important to give to the patients. Then they need adapting the home environment, okay? Adapting the home environment for ease of function, safe accessibility and mobility. Now without the adaptation of the home environment is very important for a patient. Just to give an example, I have some patients from Mizoram. Mizoram is a place which is very steep, very hilly, and there are many stairs, okay? So the first question that the patient asks is, after I fit with this limb prosthesis for the lower limb, will I be able to walk a stairs of around 50 flights of stairs? My answer is yes, but depending upon the types of prosthesis fitted. In the market nowadays, we've got various types of prosthesis, okay, which is energy saving prosthesis, we call energy saving, which means a patient doesn't need to exert so much energy or expend so much energy to ambulate around, especially in hilly terrains. Okay, then comes the patient family and education. These all are the amputation rehabilitation programs related to prosthesis. Okay, then I shall come to the upper extremity amputation. Why I'm talking about the amputation levels, because depending upon the level of amputation, the prosthesis are also fitted in that manner. Okay, so when you come to the upper extremity amputation, you can see there's a partial hand amputation. A partial hand amputation, which means just a part of the hand. Then we have a wrist disarticulation. I think everybody knows the wrist. Then the transradial or the below elbow amputation. Okay. Then comes the elbow disarticulation, transhumeral. Okay, which means within the humerus. Any part of the humerus amputation is known as a transhumeral or an above elbow amputation. Then we have what is known as a shoulder disarticulation. I have kept only one picture in this case of a partial hand amputation. You can see there. This patient is a burn injury patient actually, but his digits were not that intact, okay, were not that looking good. So this is a partial cosmetic restoration of the hand, okay. You can see there, all his fingers there except his thumb and index fingers there, which means you can still use the gripping and a grasping function, okay, with one thumb and one finger. But the other fingers are all gone, okay. In this case, we have to do a cosmetic restoration, okay, which means as a partial finger prosthesis or cosmetic prosthesis. Okay, I'll show you the gloves in the later slides. I'll be showing the gloves. But this is one of the amputation which is known as a partial hand amputation. Now, if you go to the wrist, it's known as a wrist disarticulation. Above the wrist is known as a transradial or below elbow amputation. At the elbow level is known as a elbow disarticulation. Then comes a transhumeral. I think in the amputation classes taken, these details have been told. Okay, this is just for your revision. Then comes the lower extremity amputation. In the lower extremity, starting from the foot, there's a partial, okay, which toes, when the toes are taken off, or part of the foot, okay, from the calcaneum level or talus level, any amputation that happens in that region is known as a partial foot amputation. Then at the ankle, when the ankle is done, is known as an ankle disarticulation or a Symes disarticulation, okay, a Symes disarticulation. Then comes the below knee or transtibial amputation. Then comes the knee disarticulation, the above knee and the hip. Okay, these are different levels of amputation, and depending upon the amputation levels, the process is given accordingly. Okay, I have a picture here of one of the amputees here. This, as you can see, all his foot, I mean the part of a foot from the MTP region, which means the metatarsal phalangeal joint has been removed. Okay, you can see the suture still there. This is a partial foot amputation, wherein the calcaneum and talus is still intact. Okay, this is a partial foot amputation, and the rest, as we go upwards, different levels of amputation comes. Okay, now when I talk the part of an upper extremity prosthesis, The one you're seeing here in the slide is a below elbow, okay? It's a below elbow prosthesis. Because this patient is having a congenital, remember I've told you about a congenital amputation. This patient is a congenital amputee, which means the whole of the hand wasn't developed properly. His hand was not totally developed. Only the radius was developed and a small finger was there. Okay, so this is a below elbow congenital amputee. You can see there, that's the inner socket. When we're fitting, we're using electrodes for the hand movement. Okay, these use EMG signals. This process uses EMG signals. Okay, the EMG signals of the body transmit through the brain are being transmitted to do the function, opening and closing of the terminal device. You can see there the terminal device over there, the hand, which is known as terminal device, that opens and closes through the electrodes which is being supplied from the muscles of the residual muscles of the patient. Okay, you got it? You can see there's one device there, white color device. White color device is there, that's the battery, and you can see the gloves. That's the cosmetic covering of the hand. Okay. In this, what we have is a socket. You see the white color, which I'm holding. The socket that I'm holding, that's not the socket. The thumb goes inside the socket. Okay, the thumb goes inside the socket. That's the socket. Then comes the wrist unit and the hand unit. Okay, in this case comes only the wrist unit and the hand unit along with the gloves. Okay. This is known as a myoelectric prosthesis. Myoelectric prosthesis. Okay, but due to the expense, because of the expenses, patients don't usually prefer to have these. What patients usually use are, okay, now as you see here, as I've talked to you about just now, was a myoelectric prosthesis. The one you see in the picture here now is a conventional prosthesis, okay, or body powered prosthesis. It doesn't use batteries, it doesn't use the EMG signals, but it uses the muscles of the shoulder to open and close the terminal device. You can see a cable. There's a cable running just laterally to the hand. That's the cable connects to the shoulder. Okay, there's a kind of figure of 8 strap. Figure of 8 strap that goes into the shoulder, both shoulders. Figure of 8 strap goes, and this cable controls the opening and closing of the hand. Okay, same system. You can see the brown color, the light brown or the yellowish color. You can see there. That's the socket. That's the socket part. Then we have the gloves. You can see this cosmetic gloves covered. This gloves doesn't go entirely up to the proximal part of the socket. It goes only a little bit half of the socket because the patient usually wear long sleeves. Okay. So this is a normal hand. Okay. But there's some people who wants to use what we know as a hook. I think hook also are being used. Most importantly, many people in America, they use hooks instead of the hand. But out here, because of the cosmesis, people prefer to have a normal hand look-alike prosthesis. Okay, so this is a conventional below elbow prosthesis. Okay, a conventional below or body powered below elbow prosthesis. Now what we have here is an above elbow prosthesis. You can see from the shoulder, the socket extends to the shoulder level. And the patient is holding something there in his hand, and you see the straps. Same thing. This is a body powered. Okay, you can see one cable is running parallelly to the socket in the arm. Okay, in his arm you can see the cable running. That's the cable control for the elbow. Okay, because the elbow have to flex, and sometimes it has to stop in a particular area for the patient to perform the activities. Okay, then there's another cable running posteriorly that's for controlling the terminal device. Okay, now what we have in this above elbow process is a socket. We have a socket unit, then we have an elbow unit, okay, elbow joint unit. We have a forearm shell, then we have the wrist unit and the hand. Okay, these are the different components of the prosthesis in case of an above elbow amputation. Okay, so I won't go into details of what's there, what's not there, how to fabricate, but just the components that you'll understand what are the parts of the upper extremity prosthesis in case of an above elbow. Okay, so the difference here is that with a below elbow and above elbow, the difference is that in a below elbow we don't need an elbow unit, okay, or an elbow joint, because the normal ankle joint is still there. Okay, so in case of an elbow disarticulation also, we need and we require to have a elbow unit. Okay, but in case of below elbow, we require only the hand, the wrist unit and the socket along with the cable system. Okay, I think hope many of you clear. Okay, so if you have any doubts, you can browse in the internet and you can find it out the various components, how it works. Okay, So this is a body power. He uses his shoulder, the retraction and the abduction of the shoulder opens and closes the terminal device. Okay, retraction also again does one thing, locking and unlocking of the elbow joint. Okay, now when you go to the lower limb, you can see there is an above knee prosthesis we known as. This is an above knee prosthesis. This is meant for a bilateral amputee. Actually, this patient was amputated bilaterally. Both the limbs were amputated from above the knee. So here we're using different kinds of joint. You can see one is a safety knee I've given. The other is a 4-bar polycentric knee. Okay. Now we have the same system here. We have the socket. You can see the yellow color along with the harness over there. You can see that's the socket part. Okay. Then comes the knee joint, right at the knee level. Then comes the knee joint. Then comes the pylon, and then comes the foot piece. Okay. This is a prosthetic foot. Okay. And the whole limb is a prosthetic limb. Okay. So these are the components. The socket is always hollow. Remember, the socket is always hollow. The stump goes inside the socket. Okay, the stump goes inside the socket. The socket is always a hollow place where the patient puts in. Okay. Now, one important thing about the lower limb prosthesis, or in this case, above knee prosthesis, the weight bearing area. Many of us will wonder, where will the patient bear the weight? Okay, where will the patient bear the weight? The area of weight bearing in this case will not be the distal end of the stump. Many of the people used to think that the weight bearing area will be the distal end of the stump. It's not the distal end of the stump, rather it is the ischium. Okay, the ischial bone. Okay, the ischial bone bears the total weight of the limb. Okay, which means the whole weight is transmitted on the ischium. We made an ischial containment socket, we call it. Ischial containment socket. It's where the ischium sits and the whole weight is transferred there. Okay. In case of an above knee prosthesis, not on the distal end. Okay, if weight is taken on the distal end, the patient will have pain, because what happens is that the femoral distal end will poke in on the distal tissues. Okay, on the distal tissues of the stump, causing severe pain to the patient when he won't be able to use the prosthesis. So in this case, we call it as a ischial weight bearing prosthesis. Okay, ischial weight bearing prosthesis. Now, when we come to our lower limb, you can see here this amputee is also a bilateral amputee. Okay, one side is above knee, the right side, the left side is a below knee. Okay, this was during the trial stages, that's why you can see those blocks, wooden blocks, because of the height. Okay, in determining the height here, it's very difficult for determining the height of the patient, because the patient usually doesn't remember his height. Okay, his total height. So this is how we determine the height, by using the outstretched hand. Okay, using the outstretched hand and taking 1/3 of the entire outstretched hand, we get the length of the limb. Okay, in this case you can see on the left side, that's a below knee prosthesis. You can see a kind of a groove right below the knee on the socket part. On the socket part is a kind of a groove right below the knee. That's the patellar tendon. Okay, so this below knee, usually the weight is taken in the patellar tendon bearing area. The patellar tendon bearing area takes the weight of the below knee prosthesis. Okay, remember that. Patellar tendon bearing area takes 90% of the weight, whereas 10% is borne by the medial aspect of the limb. Okay, of the stump. Medial aspect of the stump takes 10%, 90% of the weight is borne by the patellar tendon bearing area. Okay, I think you're clear with that. Okay, this foot given here is a carbon foot. Okay, it's an energy storing foot. Because of the severity of the amputation of the patient, we have given him a energy saving foot. Okay, which means when a patient walks, energy is stored, and then the energy is again released through the cycle of walking. Okay. I could put a video on the slide, because there's always a problem with the videos whenever you keep the slide. So this is the raw form. Okay, this is the raw form of prosthesis without a cosmetic covering. So after the cosmetic covering is given, this is how it looks. Okay, this is the foam that's covered on top of the pylon. Okay, on top of the socket. So you can see here we have given the foam covering along with the belt suspension. Okay, now in this case of below knee or lower limb prosthesis, what we do is that the suspension is given by usually a suspension sleeve. In case of below knee, we give a suspension sleeve. Okay, and in case of above knee, okay, above knee or in the thigh level amputation, we give a suspension known as a Salesian belt. Salesian belt suspension. Okay, we give what is known as a Salesian belt suspension. Now, coming to the care, because I haven't prepared more slides, but coming to the care of the prosthesis. In these cases, when a patient uses a prosthesis, sweating will be there. Lots of sweating will be there. Sometimes what happens is that the patient doesn't take care and infection might again recur. Okay, so it's very important to counsel the patient on the care of the prosthesis and the limb. Okay, so what we do is that for cleaning purposes, we ask the patient to use only a light Dettol solution. Okay, light Dettol solution, wipe it all around the socket part and pour some talcum powder so that no fungal growth happens within the socket. Because if there's some fungal growth, then there will be skin irritation and there will be damage of the skin. Okay, so in that case, we ask the patient to use a slight amount of Dettol solution, wipe it clean, then pour talcum powder and sometimes put in the sunshine. Okay, so that it kills all the bacteria and the fungus. Now, important thing about care of the limb also. Sometimes what happens is that a patient, after having a kind of a pain, okay, because using a process sometimes develop a kind of scarring of the overlying tissues. A little bit of scarring happens. Okay, sometimes it's a breakdown of the skin. The patient doesn't know. He keeps on using the prosthesis. That might lead to secondary infection again. So it's very important to tell to the patient that in case of any eventuality of scarring or any breakdown of the skin, the patient needs to stop using the prosthesis for a few certain of days. Okay, it's not that you have to continue using it, but you have to stop using the prosthesis. Okay, so it's very important that a patient has to do that. And another thing, important thing is that while using a prosthesis, the measurement, okay, the measurement or the circumferential measurement or the volume of the stump will reduce. Okay, when a patient first comes, we take the casting, the measurement is different. After he uses the prosthesis, say for around 6 months, then the measurement will reduce. Because what happens is that all the fatty deposits, the musculature is all being burnt up, okay, and it becomes contract. The muscle contracts. So once the muscle gets contracted, there will be a volume reduction, okay. So what happens that in the experience I face, a patient after fitting the limb, say after 2 months, 3 months, he calls up and says, my limb is getting loosen up. What happened? What is wrong? The main important thing is that there's a volume reduction in the entire circumference of the limb, okay, of the anatomical limb. So in that case, there'll be a need to change the socket again. Okay, there'll be a need to change the socket again. So I think these are the only things I think we learn about prosthetics. And I hope like if you've got any doubts or any queries you want to ask, you can reach me at Balapran, you can call your tutor, you can reach me at the Orthopedics department. Okay, so I think this is it. And thank you for your patience and your listening. Thank you.